All right, class, let's walk through the management of burn injuries. Burn care is one of the most complex areas of nursing because it doesn't just affect the skin. It involves multi-system pathophysiology, and our role as nurses is central to whether a patient survives and how well they recover. We divide burn recovery into 3 overlapping phases: the emergent or resuscitative phase, the acute or intermediate phase, and the rehabilitation phase. Each phase has its own nursing priorities, so let's start at the very beginning. The emergent phase. The emergent phase begins at the time of the burn injury and continues for about 48 hours, or until fluid resuscitation is complete. The main goals in this stage are to maintain an open airway, support breathing, stabilize circulation, prevent shock, and control pain, all while protecting the wound from further contamination. If you're ever at the scene, you immediately follow your ABCDEs: airway, breathing, circulation, disability, and exposure. Flames must be extinguished, clothing and jewelry removed, and the burn cooled, but never with ice. A clean, dry covering is applied to reduce heat loss and contamination. With chemical burns, the rule is copious irrigation, sometimes for hours. Now, here's a nursing safety alert. Airway obstruction is the single biggest danger in the first hours. Clues include singed nasal hairs, soot in the mouth or sputum, hoarseness, stridor, or a history of being trapped in an enclosed space. If you see these, anticipate early intubation. We never wait until edema closes the airway. Administer humidified oxygen, monitor arterial blood gases, and bronchoscopy may be ordered to confirm inhalation injury. Circulatory collapse is the other major threat. When burns cover more than 20% of total body surface area, the capillaries become leaky, plasma shifts out into the interstitium, and the patient can go into burn shock. The Parkland formula is our starting point. 4 milliliters of lactated ringers per kilogram of body weight per percent TBSA burned, with half given in the first 8 hours from the time of injury, and the rest over the next 16. But formulas are just a guide. The real measure of adequate resuscitation is clinical. Urine output should be 30 to 50 milliliters per hour in adults, or 1 milliliter per kilogram per hour in children. Blood pressure, heart rate, mental status, and lactate are also monitored closely. Electrolyte shifts are just as important. In the emergent phase, potassium is often high due to cell destruction, and sodium drops from fluid shifts. As the patient moves into the diuretic phase, potassium falls and hyponatremia can worsen. Nurses must recognize these changes and anticipate interventions. Pain management is a constant priority. The patient is in excruciating pain, but intramuscular or subcutaneous injections are unreliable because of impaired absorption in shock states, and oral medications are not practical early on. That's why we use intravenous opioids, titrated carefully. You'll also want to anticipate procedural pain, for example, before a dressing change, and coordinate medications so the patient has adequate relief. Nurses are also watching for complications of smoke inhalation and carbon monoxide poisoning. Carboxyhemoglobin levels must be checked, and the patient treated with 100% oxygen until levels normalize. Now let's move into the acute or intermediate phase. This usually begins 48 to 72 hours after injury, once capillary permeability improves and diuresis starts. At this point, the patient is no longer in immediate danger of shock, but our focus shifts to wound care, infection prevention, fluid and electrolyte balance, nutritional support, pain control, mobility, and psychosocial care. This phase can last weeks or even months. Pulmonary issues remain a serious risk. Mucosal sloughing can obstruct the airway, pneumonia can develop, and some patients progress to acute respiratory distress syndrome. Nurses monitor breath sounds, secretions, ABGs, and oxygenation. Early tracheostomy may be considered if prolonged ventilation is expected. On the cardiac side, the danger is now fluid overload. Remember, all that edema fluid is moving back into the circulation. Patients can develop pulmonary edema or heart failure. You'll notice crackles, dyspnea, jugular venous distension, or decreasing urine output. Management may require diuretics, oxygen, and careful fluid restriction, guided by invasive monitoring. Infection prevention becomes the cornerstone of nursing care. The burn wound is the perfect medium for bacteria and fungi. We use meticulous barrier precautions, strict hand hygiene, and environmental cleaning. Wounds are cleansed daily with mild soap and water, and hydrotherapy may be used. Hair is clipped away from wounds, and all equipment is disinfected between patients. Cross-contamination is a constant threat. Topical antimicrobial therapy is standard. Silver sulfadiazine is common, but you'll also see mafenide acetate, silver nitrate, or silver-impregnated dressings. The goal is to prevent colonization and invasion while minimizing toxicity. Dressings are applied in multiple layers, wrapping from distal to proximal, with each finger and toe wrapped individually to prevent webbing. Circulation must be checked frequently. Too much pressure can compromise perfusion. Debridement is critical. Dead tissue acts like a petri dish, and it must be removed. We use several methods. Natural debridement, where the body sheds necrotic tissue on its own. Mechanical debridement, where dressings are removed and tissue cut away. Chemical debridement, using enzymatic agents. And surgical excision, which is early removal of eschar down to viable tissue, often followed by grafting. Surgical debridement has dramatically improved outcomes, but it comes with risks like blood loss requiring transfusion. Grafting is performed to close deep burns, reduce infection risk, conserve fluids, and preserve function. Autografts, using the patient's own skin, are the gold standard. Split-thickness grafts may be meshed to cover larger areas but leave more scarring. Sheet grafts are more cosmetic but require a larger donor site. Donor sites themselves are painful and must be managed carefully for infection and comfort. We also use biologic dressings like homografts from cadaver skin or xenografts from pigs, and increasingly biosynthetic and synthetic substitutes, though cost can be a limitation. These provide temporary coverage, reduce fluid loss, and protect against contamination until permanent closure is possible. Pain management continues to be a round-the-clock challenge. There's background pain, breakthrough pain, and procedural pain, and each requires a slightly different approach. Intravenous opioids remain the backbone, but non-pharmacologic methods, relaxation techniques, guided imagery, music therapy are important adjuncts. Nutrition is another cornerstone. The burn patient is in a hypermetabolic, hypercatabolic state. Their caloric needs double or even triple, and protein requirements are enormous. Early enteral nutrition is started as soon as bowel sounds are present. Carbohydrates are the main energy source. Protein supports wound healing and immune function. And fats are restricted because burn patients often have impaired lipid clearance. We also see medications like insulin, oxandrolone, or propranolol used to modulate metabolism. Mobility is essential to prevent contractures and preserve function. Nurses work hand-in-hand with physical and occupational therapists to position patients properly, use splints, perform range of motion exercises, and apply pressure garments. Patients are encouraged to participate in their own care as soon as possible. And finally, psychosocial support cannot be overlooked. Patients often face anxiety, nightmares, depression, or grief over their losses. Families may feel helpless or overwhelmed. Nurses provide emotional support, facilitate coping strategies, and refer to mental health professionals, social workers, or chaplains as needed. Burn survival is not just physical, it's deeply emotional.